Hola, ¿qué tal? Estamos con el profesor Nahar hablando acerca de prostatectomía robótica y cirugía robótica en sí. Hi, Professor Nahar. How are you're doing, and how's your stay here in Cancun?
No, it's great. I'd like one more time to thank the organizing committee and everyone for inviting me. This is a beautiful venue, great meeting, made a lot of friends, had a lot of fun, learned a lot. It's been an absolute pleasure to be here.
Thank you to be here with us. And I want to start the interview about asking this process of leaving Brazil in order to another new country with a lot of expectations. How was your process of adaptation, and how did you do all what you've done?
So that's a good question. So for those who don't know, I'm originally from Brazil, from Rio de Janeiro, and I finished my residency, my urology residency, back in 2010. And I went to a meeting like this one, but in Brazil, and I was presenting, giving a talk, and that's when I met Dr. Prek, who's the chair of the urology department at the University of Miami. So he interviewed me, and basically he asked me if I wanted to come and do a fellowship. At that time, I had finished. I had my own practice and this, but again, I thought that as a great opportunity to get more experience, and I always wanted to study abroad. And so I went to U.S., did an observership there for like 3 months, and then I realized that's what I wanted to do. And so went back to Brazil, studied for the steps, finished the steps, and then in 2000 and that was in 2014 when I met, and then 2015 was when I started my fellowship. And then after I finished it, I stayed back as faculty.
And how do you go in oncology and robotics?
So I always liked like big surgeries. In Brazil, you have to, I was mentioning, right? In Brazil, you have to do general surgery before you do urology, and we do big cases. And I always liked those big cases, and that's why I wanted to do oncology. So, and the fellowship I did in the US, in Miami, was basically urologic oncology. So that included robotic surgery as well as cancer surgeries.
Great. And talking about your lecture early on, you talk about retro-sparing surgery and how do you have to individualize the cases between high risk, intermediate. So, what do you say about doing retro-sparing in all cases, or just some cases, just very individual cases?
I think it is my opinion. It's important that you have, different techniques, right? And you can tailor there towards the risk of that patient. So I do basically the retro-sparing approach as well as what the hood technique, where basically it's a hybrid procedure where I do everything, I dissect everything posteriorly, but then I drop the bladder and do the rest anteriorly. Because sometimes for patients with high risk cancer, I think with the hood technique, I get a better visualization of the contours of the prostate, and I can avoid having a positive margin. Whereas when you do a retro-sparing, you're more likely to go too close to the prostate, and it might end up with a positive margin. So I feel like for patients with high risk disease, I think you should be very careful when doing like retro-sparing. Patients with anterior lesions as well. But again, in terms of outcomes, I think, and also retros, the big prostates and big median lobes might be a little bit tricky and challenging because of you won't be able to identify the UO, and doing the bladder neck is a little bit harder. But it's a cancer surgery, right? And again, with these fascia sparing approaches, you're basically gaining 3 to 6 months of return to continence, early continence. But in the end, after 6 months, 3 to 6 months, everyone is doing the same. So I think cancer is a priority. If you feel more comfortable doing the standard approach, that's the way you should do it.
And have you aborted like the surgery because of the stickiness of the prostate to the rectum, or you haven't?
I like to, again, I always do MRIs beforehand, so for strategy. So I like to plan the surgery ahead, so I know if the cancer is too close to the rectum, there might be an issue. Again, if you have to take a prostate out, that's the indication. If it's too stuck, you have to bite the bullet. Sometimes you might have an injury. You're gonna discuss that with your patient. You do a finger exam to see if it's stuck to the rectum or the rectum is free. But sometimes if you have to do it, you decide to do it rather than doing radiation, then you can always fix it. I would never abort a surgery just because of that.
Okay. And how about the use of single port versus multi-port in oncology surgery, and in red sparing surgery?
Okay. For the red sparing specifically, so we do have the single port. I do single port, and I do multi-port as well. For the single port, the red sparing, I think it's because the way we do it is peritoneally. When you do it transperitoneal, I feel like you have a lot of space, so you can do the multi-port. The single port is only gonna slow me down because you have to do like baby steps. Everything is slow, different than you have all the range of movement with the multi-port. But when I see patients with really hostile abdomens, previous surgeries, colostomies, all those things, I like to stay and I want to stay outside.
Compartmentalized.
Exactly. If I want to stay outside of the abdomen, outside of the peritoneum, and I do extra peritoneum, that's what I think the SP has a great value, and I do for all my patients for extra peritoneal approach.
Okay. And just a comment to all our residents and like all the members of this society, what would you say about?
So I just want to congratulate you all for this meeting. I mean, I've been to many meetings, and this is one of the best meetings I've been. So congratulations on that, and all the residents and fellows. I think you have great speakers here, great urologists here in Mexico, like yourself.
Thank you.
And and I think it's if Miami is just like 2 hours away, I'll be more than happy to welcome you there as well. And but again, congratulations on this great meeting.
Thank you for for coming. Thank you for being here with us, and we have a great lecture from you, and hopefully you like it. Thank you.
Thank you.